Good evening, everyone. Welcome to the Vijaya Diagnostic webinar series. Myself, Dr. Mounika, consultant radiologist in Vijaya Diagnostic Center. Today, our webinar topic is early first trimester ultrasound. As all of us know, nowadays, so many ectopic pregnancies and so many failed pregnancies are increasing. It's mandatory to do ultrasound in first trimester as early as possible after confirmation of urine pregnancy test. And today in our discussion, the topics are about sequential findings in first trimester, and suspicious and diagnostic signs of failure pregnancy, and signs of ectopic pregnancy, and signs of molar pregnancy. Today, our chief guest is Dr. Pratyusha, ma'am. Good evening, ma'am. Welcome to the webinar, ma'am.
Good evening, ma'am.
Dr. Pratyusha, ma'am, she is working as associate professor at Mallareddy Medical College. Madam has 13 years of experience in obstetrics, and she has completed her MBBS, MD, MRCOG, CMIP, and FMAS degrees. She is very expertise in obstetric and gynecological procedures, and also in laparoscopy and hysteroscopy procedures. She has very good communication and surgical skills. Thank you for attending our webinar, ma'am. Thank you, ma'am.
Thank you so much, ma'am.
Next, our speaker, Dr. Shabana, ma'am. She is working as consultant radiologist in Vijaya Diagnostic Center. Madam has around 13 years of experience in radio diagnosis. She is very expertise in obstetric and routine ultrasounds and other radiological procedures. Thank you, ma'am. Let us start the topic now.
Good afternoon, everyone. Right. Welcome to the webinar. Thank you, Mounika, for the introduction.
Thank you.
Thank you, Dr. Pratyusha, madam, for coming to our webinar as a guest speaker. To start with, the topic of today's discussion is early first trimester ultrasound. So I'm just going to highlight the very important points that we usually see in day-to-day early pregnancy scans. So in today's discussion, we are going to talk about normal sequential events that occur in early first trimester, the suspicious and diagnostic sonographic findings of the failure of early pregnancy, few points about subchorionic hemorrhage, ectopic pregnancy, and gestational trophoblastic disease. To start with, uh, the early findings, I mean, normal sequential events that occur in the early pregnancy. So, the early sign of pregnancy we see on ultrasound is the implantation of the blastocyst. So, here we are seeing a small anechoic cystic structure with the echogenic rim. So, this is known as intradecidual sac sign, which is very early to see in a normal intrauterine pregnancy. So, these echogenic rims. This is the decidual capsularis and this is decidual parietalis. And sometimes we can see a thin rim of fluid which is present within the endometrial cavity where the implantation happens. So this is seen as early as 4 to 5 weeks of gestational age. So now we see the gestational sac which has been implanted. Usually this is seen as a small eccentric structure. So this is the normal lining of the endometrial cavity and this is the early gestational sac. So here this image I have kept beside it. This is to show that this is the fluid collection in the endometrial cavity which is known as a pseudogestational sac, which is not to be confused with the early intrauterine gestational sac which doesn't show the typical decidual sac sign. So this kind of appearance may be seen sometimes in ectopic pregnancies where there is some fluid collection in the intrauterine cavities. So these features are seen between 4 to 5 weeks. So next to appear in line is yolk sac. So yolk sac usually is seen to start between 5 to 5.5 weeks. So yolk sac is a small cystic structure with an echogenic rim, well-defined rounded structure, which usually do not exceed more than 5 to 6 of diameter. So after the appearance of yolk sac, we see the formation of a small embryonic structure. So this is known as yolk sac embryo complex. So this is seen between 5 to 6 weeks, and now it is when we start appreciating the embryonic cardiac activity. So once we start depicting the embryo yolk sac and heart activity, subsequently, we tend to see the embryo growing in its size and the small thin rim of structure that is surrounding the embryo, that is known as an amnion. So now at this point, the yolk sac becomes extra amniotic, that is, it gets separated from the embryo, which is seen as a extra amniotic structure. So this is the image which depicts the normal yolk sac, embryo, and the amnion surrounding the embryonic structure. This is the 3D image showing the same. So these are the all findings that we see in the normal early pregnancy. This is the timeline which depicts, this image depicts all the sequential events. So now, why is it important to diagnose the failure of early pregnancy? This is to prevent any inadvertent loss of or termination of potentially viable pregnancy. So to discuss with all these things, we have classified how to find the findings of the suspicious and diagnostic parameters that show that it is a failed pregnancy. So based on MSD is the mean sac diameter, which is usually taken in the early gestation. So when the mean sac diameter is 25 and there is no visible embryo, so this is the time when we say it is diagnostic of failed pregnancy. When the mean sac diameter is less than 25 this range between 16 to 24 and there is no visible embryo, it is not diagnostic, it is suspicious. So you have to wait at this point, not labeling as diagnostic, and you have to repeat a scan after a week to see if there is any interval change or growth. So based on CRL, how do we classify? So CRL measuring 7 and there is no heart rate, so it is considered to be diagnostic for failure. CRL, if it is less than 7 and there is no heart activity, it is not considered to be diagnostic, it is suspicious. So you have to wait in this patient and you have to repeat a scan later to see if there is any interval change in the appearance of heart activity. So we can even use the time-based criteria also. So this is the early scan which shows a gestational sac and a yolk sac. So after 2 weeks, there is no development of any embryo also seen in this patient. So this is considered to be a failure pregnancy. So 2 weeks later also there is no development of embryo, which is the time-based criteria which we use for considering as a failure of early pregnancy in this case. So quickly going through the findings that are diagnostic, the mean sac diameter, the diameter that is 25 which is very important here with no embryo, CRL 7 or more than 7 with no heart activity, and if we see a gestational sac without a yolk sac, so you have to wait at least for a span of 2 weeks to see if there is any development of embryo with heart activity. If there is no development, then you consider it as a failure pregnancy. And if there is a yolk sac seen, you have to wait without an embryo, without any heart activity. You have to at least wait for 1.5 weeks to see if there is any interval change of development of embryo and heart activity. So findings that are suspicious, we have already seen that less than 25 sac, less than 7 CRL, and gestational sac without an yolk sac and absent embryo, you have to wait at least for a span of 1 to 1.5 weeks to confirm it is a suspicious or failed pregnancy. Next, after LMP, if there is no embryo development after 6 or more weeks, that is also considered to be suspicious. Any empty amnion, that is, we see only a cystic structure, but there is no development of any other structures, or there is an enlarged yolk sac, which is the structure measuring of more than 7 then we consider it to be suspicious. Another entity, when there is a small gestational sac in relation to the embryo, that means the difference between the gestational sac and the embryo is less than 5 This is also considered to be suspicious. These all things needs to be followed up rather than labeling as diagnostic to be a failure of early pregnancy. pregnancy. So this is one image that is showing you the sac diameter and embryonic measurement, which is less than 5 mm. This is considered to be as first trimester oligohydramnios. So this is highly suspicious. So this patient needs a follow-up. Here we see embryo enlarged yolk sac, which is literally looking more than 7 mm. So in this kind of appearance of early pregnancy, you have to wait and you have to do a follow-up scan. So these are few images which show that these pregnancies needs to be followed up. This is a large irregular gestational sac, large yolk sac, and this is a sac showing less than 5 mm difference between CRL and MSD. And this is a sac where they're showing a large amnion, which is having a small eccentric calcified yolk sac. So these are highly suspicious of failure of early pregnancies. So next, coming to the heart activity, even heart activity can give us some clue about the failure of the pregnancy. Usually, up to 6.2 weeks, 100 beats per minute is considered to be normal. So if it is less than 100 beats, that is between 80 to 100, so they are highly suspicious for further viability. So these kind of patients need a follow. So after 6.3 to 7 weeks, the heartbeat should be at least 120 beats per minute. If it is less than 120 beats per minute, ranging between 100 to 120. So these patient also needs follow-up. So next, coming to subchorionic hemorrhage, which is a common cause of bleeding per vaginum in early pregnancy. So this is a collection of blood between the uterine wall and chorionic membrane. So this image depicts the collection of fluid, that is the blood between the chorionic wall and the uterine wall. So this can be acute or chronic. When the bleeding is acute, we can see the collection as little bit hyperechoic, which would be little difficult to see on ultrasound initially. As the timeline advances, we see the collection becoming more hypoechoic, which is seen very clearly in this image as a hypoechoic collection adjacent to the gestational sac. So based on the collection, we can classify whether it is a small bleed or it is a large bleed. So if it is less than 20% of the sac diameter, it is considered to be smaller bleed. And a medium collection will be ranging between 20 to 50% of the sac diameter. Larger bleeds occupy more than 50% of the diameter of the sac and usually have a worse prognosis. So these needs to be followed up timely. So this table that just depicts us how the early pregnancy failure looks like. So it can be in different forms. It can be initially a threatened abortion, or it can be inevitable abortion, incomplete abortion, missed abortion. In inevitable abortion and incomplete abortion, usually the bleeding happens with opening of the cervical internal os. Threatened abortion, usually the bleeding happens without any obvious cervical dilatation. In missed abortion, we see the products within the uterus without any expulsion of the products, and we see that there is no heart activity, though the presence of embryo or gestational sac is present. Now, few points about the retained products of conception. So, after the abortion, sometimes it happens that the products are not completely expelled out. So, how do we diagnose this on sonography? So, when we do a scan, we see thickened endometrium, which is more than of 10 mm usually, or there is some mass-like structure within the endometrium. So when we put a color Doppler, it is vascular. So it is very important for us to do a follow-up for this patient to see whether the products are completely expelled or no. So the differentials for this would include AVM, which is highly vascular and usually more towards the myometrial margin. So now a few points about ectopic pregnancy. Ectopic pregnancy has been showing so much increased incidence recently because of increase in the incidence of the risk factors. So the risk factors usually include like tubal problems, like previous tubal pregnancies, PIDs, endometriosis, and recent increase of IVFs also has increased the incidence of the ectopic pregnancy. It is very important for us to detect because it will decrease the morbidity and mortality, and we can give better, less invasive treatments to the patient if they are detected early, and for better preservation of the future fertility of the patient. So the patient usually presents with triad of bleeding per vaginum, adnexal mass, pain, abdomen. So here we can see the uterus, which is empty, showing thickened endometrium. Here there is one adnexal mass, and this has already given away, and there is some fluid collection in the peritoneal cavity. So this is a uterus which shows some collection of fluid within the endometrial cavity known as pseudosac, which needs to be differentiated from the early residual sac sign of normal pregnancy. So the image here shows this is a normal fallopian tube and ovary here, and this is the patient with ectopic pregnancy where the ovary is normal, and the fallopian tube shows an adnexal mass, cystic structure with echogenic rim. Here we can see a small yolk sac-like structure. So this is the right. This is a tubal pregnancy. This image also depicts the same empty uterus, right ovary, and this is the right tube where the implantation has happened. And in this image, we can see some collection also. Some key points where we can talk about the diagnosis of the ectopic pregnancy. Usually, it can happen on the same side of the corpus luteum, and on color Doppler, the adnexal mass can show ring of fire, which is even seen in corpus luteum also. It is not diagnostic feature of ectopic pregnancy, though. So, the diagnosis of a ruptured ectopic pregnancy. So, it is not that always a ruptured ectopic pregnancy, the bleed in the pelvis or the hemoperitoneum signifies that it is a ruptured ectopic pregnancy. Sometimes it can be a leaking ectopic pregnancy from the fimbrial end of the fallopian tube. So, whenever we see fluid in the peritoneal cavity, it doesn't mean that it has ruptured. But yes, sometimes the amount of free fluid is a predictor of the rupture. So larger fluid volumes in the peritoneal cavity can be suggestive of a ruptured ectopic pregnancy. So in the ultrasound report, we can what is important that we have to report so that it will help the gynecologist for further management. So along with the blood reports, the levels of beta HCG, we have to mention about the absence of the normal intrauterine pregnancy, because sometimes it can be a heterotropic pregnancy also, happening in both uterus and tube. So we have to rule out the normal absence of intrauterine pregnancy, and the presence of the adnexal mass and its size, because size is important, which will help in change in the management also. Presence of cardiac activity in the embryo and the yolk sac, and the presence and the amount of the pelvic fluid. So we have to mention if the fluid is localized to the pelvis, or whether it is reaching up to the hepatorenal space or glenorenal space. The amount of fluid can be quantified this way: mild, moderate, and large. So now coming to the gestational trophoblastic disease, these are also common in early pregnancy because they are only picked up very much in the early pregnancy. So these usually arise from placenta, can be benign or malignant. So the patient presents with high beta HCG levels and hyperemesis gravidarum. So we have two types in this: complete molar pregnancy, partial molar pregnancy. Usually in complete molar pregnancy, we don't see any fetal parts and the uterus is enlarged. And on ultrasound, we see typical enlarged uterus with multiple cystic spaces which represent the degenerated chorionic villi. In partial mole, we see a small fetal part along with the this enlarged placenta, which is seen as a small cystic, multiple cystic areas within it, which can be challenging sometimes for us to diagnose this kind of appearance with partial mole. So this is a video to just show how the ectopic pregnancy looks like. So this is the uterus retroverted. Uh, we are seeing the endometrium here, which is and the uterus which is empty. There is a free fluid in the POD, which is showing some internal echoes. Now, as we move towards the adnexa, here we are seeing a corpus luteal cyst. And now this is the adnexal mass. Here, this is the right ovary with corpus luteum, and this is the free fluid, which is representing the collection in the pouch of Douglas. So when we give some pressure, we can differentiate between the ovary and the tubal structures. So this is the adnexal mass that we measured here. So this structure depicts the tubal pregnancy. On color Doppler, this can give a peripheral hyperechoic pickup on Doppler, which is known as ring of fire. Fluid with particulate kind of echoes, which represent hemoperitoneum. So the take home points are like, for the we have to first locate the pregnancy. So based on the parameters I've told you, the measurements, we can classify as diagnostic of failure and suspicious but not diagnostic for failure, and follow-up can be done in 1.5 to 2 weeks to confirm it. For differential diagnosis of pregnancy of unknown location, we have to rule out an early intrauterine pregnancy. Sometimes the implantation may be late, so we have to wait and watch. Initially, we can see only thickened endometrium, though the UPT or serum beta HCG is positive, or it can be because of any failed pregnancy, or we have to rule out ectopic pregnancy when we don't see the normal intrauterine pregnancy. And correlation with serum beta HCG levels are very important, and follow-up USGs are always recommended. When there is no intrauterine pregnancy and you see a mass separate from ovary, we have to rule out ectopic. And when there is early first trimester bleeding, we have to rule out the retained products of conception, and we have to rule out, we have to differentiate from the other entities like submucosal fibroids, polyps, and avascular malformations. And early pregnancy with GPDs can show cystic changes in the endometrium. So it's important to rule out the partial and complete molar pregnancies also. Okay.
Excellent presentation, Dr. Shabana ma'am.
Thank you.
Pratyusha ma'am, please give your valuable suggestion for us.
Yeah, yes, ma'am. Dr. Shabana, it was a very excellent presentation, and you have given the information which is actually needed for a radiologist, as well as a minimum information which every gynecologist also should know when they are doing a scan at least. So I would like to add on one or two clinical points. And the first thing is about this, you have already mentioned about the intrauterine pregnancies as well as the ectopic pregnancies, right? Those two you have mentioned, but one more thing which is a thing which we are also concerned is that is a pregnancy of unknown location.
Yes.
Okay, that we will be diagnosing based on the beta HCG value. If the beta HCG, where the cutoff is 1500, more than 1500 beta HCG, when there is no intrauterine sac, we generally take it as an ectopic. With any clinical signs, yes, we put it in an ectopic. But if the value is less than 1500, then what we have to do is we have to go measuring the beta HCG value after 48 hours, not before, always after 48 hours, where there is at least a 63% rise in beta HCG value. Okay, this shows if there is a rise of more than 63%, then you put it as a normal intrauterine pregnancy, which is happening. Or if it is the rise is less than 50%, then you can also think of a failing pregnancy. That is, it is going towards abortion. But if the range is falling between 50 and 63%, that is the area where we are more worried, where we have to strictly follow up the patient with a regular beta HCG value to rule out this, or to follow up or early diagnosis of an ectopic pregnancy. Ma'am. And one more point, ma'am, regarding molar pregnancy, it is sometimes difficult to diagnose a partial molar pregnancy on an ultrasound. So what we advise is always whenever we evacuate, we have to send those products for histopathological examination. That is always to be done for diagnosis.
Thank you,
Ma'am,
ma'am.
one doubt I have, that is, I
Yes.
have read regarding this comet sign.
Comet sign.
COMAT. Yes, ma'am.
Comet sign in which entity? In which pregnancy?
Yes, ma'am. Comet sign is something, it has been given in an very early pregnancy, around maybe 2 or 3 days after implantation or too early. It is something based on the vascularity,
Okay. Okay.
where implantation is taking place.
Yeah. Practically little difficult probably.
Practically, actually, I think we don't do.
Okay.
By the time, I think it is difficult to diagnose also, but
Yeah.
it is one thing that is mentioned.
Okay. Okay. And to add on, there are some other locations of ectopic pregnancies also,
Yes,
like
ma'am.
cervical pregnancy, C-scar pregnancy, interstitial pregnancy, angular pregnancy, which have different imaging findings. So
Yes, ma'am.
probably we can add on in other discussion for the next time
Yes, ma'am.
sometime.
We also have the cervical pregnancies also. Cervical, interstitial, and cornual. Again, we have to differentiate
Yeah.
both of them. Yes, ma'am.
Yeah. And even we have to sometimes when there is a when the uterus has some bicoordinate abnormality or septate abnormality, these things also are easily picked up in early pregnancies. So that documentation is also very important, because septate
Very.
uterus usually has a, history of early terminations. People have repeated
Abortions.
recurrent abortions rather than bicornate. Bicornate has no history of much failed pregnancies, but septate uterine structures have been having some incidents of abortions.
Yes, ma'am.
So those things are also very important to be picked up on early intrauterine pregnancy scans. Okay. Anything to
Pratyusha,
add
ma'am,
on? Yeah. Tell me,
ma'am,
Monica.
if the beta HCG is increasing but not doubling, if we cannot detect the sac in anywhere in ultrasound, you will manage the patient, ma'am?
Ma'am, if it is like more than
I mean,
1500, it
safe
depends,
side
ma'am, if it
we
is
put.
doubling. If it is
Okay, ma'am.
actually
Not
doubling,
doubling but
it is
increasing.
mostly. If it is,
Increasing
ma'am,
but
could you
not doubling. Like
increasing but
looking
not
like
doubling?
ectopic one. Signs of doubling. But we cannot
Signs of
detect
doubling.
sac
So,
anywhere in the abdomen. Uh,
okay. Then we
then
have to
safe
follow up,
side
ma'am.
will give methotrexate.
We can give,
Follow.
ma'am.
Okay. Recently
But
I
one
got
thing is,
case like that. Okay.
Hmm.
but we have to at least search, ma'am, because unnecessarily we can't go do a laparoscopy. We can't put the
Okay,
patient.
ma'am.
So what we have to do is we
Okay,
have to
ma'am.
check for the beta HCG. Depending on the value, we will
Okay,
decide,
ma'am.
and it is just for observation and follow up. First, initially, what we can do is,
Okay, ma'am. Okay, ma'am.
So in doubling, how much percentage
Okay, ma'am.
doubling is up to
doubling, we
70%?
take it as 63, ma'am, 63 to
Yeah, you
64%.
already told. Yeah.
But after 48 hours,
60.
not to
Okay.
be repeated before 48 hours.
Okay.
Okay, ma'am. In every successful pregnancy, is it normal, ma'am? I mean, every person beta HCG will be doubled, ma'am,
Yes,
in
ma'am.
48 hours in normal
Yes, ma'am.
pregnancy. Okay,
Yes, ma'am. Normal
100%.
intrauterine pregnancy,
Okay.
yes, ma'am.
Yes, ma'am. Okay. Okay, ma'am. Any discussion, ma'am?
Anything you want to ask regarding anything early
Uh,
trend?
Correct. Ma'am, one more thing, actually, what guidelines say is, if we are doing a transvaginal, because sometimes it is transabdominal and transvaginal. If
Yes.
it is
Yes.
transvaginal scan, we need to repeat it in a week when we have a doubt regarding the viability. CRL less than or 7 mm, gestational MSD 25 mm. So
Yeah.
transabdominal we can repeat it in around 2 weeks.
Okay.
But we actually follow, mostly we do a TVS, so it is
Yeah.
mostly around a 1 week
Awesome.
period.
Yeah.
Better to do TBS in early pregnancy.
Yeah. TBS is more clear and the field of view is much better.
Um,
Limited field of view, but it will give clear imageology so that we can give the measurements exactly. 1 mm difference
Yes,
also
ma'am.
is significant here. So it is better to do a TVS.
Yes, ma'am. Yes, ma'am.
So
okay, ma'am.
anything?
Thank you for attending our webinar, ma'am. Pratyusha, ma'am. Thank you, ma'am. Shabana, ma'am.
Thank you, Prathyusha,
Okay,
Thank
ma'am.
you,
madam.
Mounika ma'am and Dr. Shabana ma'am. Thank you so much.
Thank you,
Thank you,
ma'am.
Monica, for moderating the session.
Bye.
Thank you very much.
Thank you, ma'am.